optimal glycemic control, as we heard in the last discussion, 140 to 180 has a definite impact in most of the patients, not all, and we individualize the targets for our patients. So that's the preamble for the entire discussions on inpatient hyperglycemia management. So let's go on in understanding in the really critically ill patients in the ICU, what do we do and how to do them. So I'll be briefly talking about the guidelines, the targets of blood glucose levels, which have already been covered, talk about protocols for insulin infusion, glucose monitoring, and a very important part where a lot of errors happen is transiting from the ICU to the ward, from the NPO to the normal diet. That's where a lot of problems happen. So that's an area of stress in our mind when the patient is transiting. We'll talk briefly about that also. So in this case, we have a young gentleman. Dr. Sunil talked about individualizing the therapy. Like we do in the outpatient, the same or similar principles apply to the patients we see in the hospital also, in the ICU also. A young patient, expected longevity with an illness like pancreatitis, yes, is a severe illness, but the chances of full recovery and a happy discharge are very high. So what do we think here? As a clinician, what are we thinking? Yes, we need to give this patient the best kind of care, including the management of pancreatitis and glycemic control. There's no question about the fact any hyperglycemia, an inpatient hyperglycemia requiring treatment, the cutoff point is 180. Consistently above 180 requires treatment, and the treatment is insulin. For those in the critical care setting like the ICU who are not eating, the route of delivery has to be intravenous insulin, nothing else. Targets we've understood. We'll talk more about the insulin infusion, hypoglycemia. So therapy here is a balance, it's a skill, is let the sugar readings be in 140 to 180. And the very important thing which has a direct impact on outcomes and direct mortality is hypoglycemia. So you need to balance out your approach, your aggression to maintain the levels in that range and prevent hypoglycemia. There are various definitions of hypoglycemia. I'll talk about them a little later on. These are the various common published used protocols. They've been developed in specific populations. It's important to understand each one of these has been taken from a specific population, a specific team of specialists have developed them. Are these applicable to everybody? There's a question mark there. So the ideal protocol is one which you make for your institution, for your set of patients coming to your hospital, and that's exactly what we've done. But all of them work really well, and one of the metrics of any protocol is, you see in the Yale protocol, the infusion is started and then it comes down to a stable range. That's the target. Stable, not the yo-yo, hypo, hyper, like we all know about the sliding scale. We'll hear more about it when we talk in the non-critical care setting with subcutaneous insulin. But the desired result is stability in the zone of 140 to 180 for all of our patients. So will these protocols work for us? Some of these protocols are very intensive. There are two types of protocols. One are physician driven, other is a nurse driven. So Dr. Rujul said the number of patients we as a department see every day would range anywhere in between 100 and maybe going to 200 or more in a day. So is it possible for 1, 5 or 6 people to do that? No, it's not. So a protocol is one in such a setting where the volumes are very large to have something which is semi-automated. It's an intelligent system which anybody can follow, and that's the kind of protocol we follow at our center, where it's a nurse driven protocol, very simple instructions. I'll show you the protocol here and you would say this is the easiest thing to do. In fact, it's easier than the subcutaneous insulin protocol that we commonly use. So regular insulin has to be used, no other insulin, no NPH, no Lente, no basal in the infusion. It has to be regular. It's mixed with normal saline. I'll tell you exactly what we use, and you could copy the same in your practice. It has to be, now this is a common area of error. A dedicated IV route has to be there. Normally in the ICU you find a single IV line and a three-way connector there. There's an antibiotic going in one, IV fluid and the infusion. The best results would be obtained when the insulin gets an exclusive port of entry into the system for the most stable results of glycemic control. A very important caveat here is that potassium levels, please do not start an insulin infusion even in the emergency without having the potassium levels. Rather than causing benefit to the patient, this is an instant morbidity and mortality situation, which is hypokalemia. So we need to be very, very careful while using the intravenous route. Always have the potassium levels before you entail to start an infusion. Targets done, the monitoring is 1 or 2 hourly. Again, nurse driven, you have a chart in which the readings are noted, the infusion rates, will be coming to that. How to change the dose? Very simple. See, by the end of this, all of you know how to really manage the intensive care settings. 2 readings above 200, you increase the dose as per the protocol which I am going to be showing. Lesser than the range, you bring it down, and hypoglycemia would be treated. If it is 60 to 90, you give 50 ml of 25%. Even lesser than that, first of all, you need to discontinue the IV infusion. And by the intravenous route, we all know, just as you stop the infusion, the effect of the insulin is gone. So that safety parameter is there. The first patient needs to come out of the hypoglycemia, that is consecutive readings above 100. And when they reach in the hyperglycemia zone, you start the infusion at a lower rate. Another very common error in the hospital is patient is on a high dose of steroids. Suddenly the treating team decides we need to, the steroids need to be stopped. You are not informed, we are not informed. But you get a call, the patient has collapsed. What happened? Hypoglycemia. Everybody is getting angry at the team treating the hyperglycemia. It is mandatory that any major treatment change which has a definite impact on the blood glucose levels needs to be informed, and the most common of that being steroids. Make a note in red. Do that. There's nothing wrong in that, so that the treating team also knows that when the steroid doses are changed, you are informed. You can descale the therapy regimen so that hypoglycemia does not happen. And that's the real success of managing inpatient hyperglycemia, the balance of hyper and hypo leading to a range of 140 to 180. This won't be very visible, but all that I've presented is in a printable form, and it's in the files of our patients in the ICU, easily readable. They know exactly at what levels, and once you do it like 10 times, it becomes instinctive. Okay, sugar 250, column 3 I need to go at column 4 after 2 hours. It comes below, it comes like 120, you come down a column. And this is exactly how you prepare the infusion. 50 ml, 50 units of regular insulin, only regular insulin, in 49.5 ml of saline in the 50 ml syringe in an infusion pump. Glucose insulin drips are no more used at our institution, but they are used for management of inpatient hyperglycemia where you don't have infusion pumps. But this is the most precise way to deliver insulin in an ICU setting. These are the columns which I talked about. We are starting with the least intensive column, which is 1. So patients like chronic kidney disease, chronic liver disease, very thin, frail, elderly patients whom we expect hypoglycemia to happen, or hypoglycemia may be very dangerous in this set of patients. you could start, or you should start, in the earlier columns. And in a very morbidly obese patient, patient who is very insulin resistant, patient who's on a high dose of steroids, you know that whatever you do, they would require a higher dose. You can start with a column 5 or a 6 or a 7. As you start using these protocols, you know exactly in which patient to use which column. But the starting point should be insulin sensitive patient, come towards the right, insulin resistant, go to the left. And then you have an opportunity of changing the infusion rates during the hospital stay with a hourly or a 2-hourly blood glucose monitoring. And this is how the charting is done, the infusion rates. So when you're taking around in the hospital, you have this thing right in front of you. You know what has happened in the past. It helps you decide what to do now. You have the therapy chart with you. You have the patient in front of you. All of these things helps us. So you may just see the patient morning, evening, and you've taken the right decision to ensure that the glycemic levels are well maintained. So it is a nurse-driven protocol where the ICU nurses, in the ICUs mostly, there would be one or maximum, a nurse would be seeing one or maximum 2 patients. So they are dedicated to the patient, very easy for them to follow. Once they start using it, it's very easy. And in the journey of a decade being in Medanta, we've seen a drastic change in the outcome of our patients. And some of the data is also published about how well the protocols we developed in our patients, and whole lot of glucometrics, real-time monitoring, and lot of statistics and all went in to formulating these very simple protocols that you see here. An optimal protocol is one which is validated, like our protocol, which has been published already, and we've been using it for nearly a decade or more. It should be clear, it should be easy, it should not be intensive, not require calculations. The simplicity is equal to the success of a protocol. While you develop that protocol, there was a lot of complexity in developing it, but it translated into a very simple form of easily usable nurse-driven protocol. It should take into account the rate of change, and the monitoring helps us decide which direction to go with the column, the intensity. So there are several published protocols, but these are population based on teams, their specific group of patients they've been seeing. So that's how a real ideal protocol for your population comes. So the word ideal protocol is non-existent. Is what works best in your population, in your institution, becomes the ideal protocol. And we should, along with this, have the hypoglycemia directions, how to manage it, which that sheet which I showed you has directions in when the blood glucose levels are this. Obviously, the clinical picture is number one, but then the levels of blood glucose tells you what to do in resuscitation from hypoglycemia. Transiting into subcutaneous insulin, well, all patients who are on large doses, they would require. In my experience, maybe 1 to 5% of ICU patients don't require insulin outside the ICU. Most of them, 95-98%, require subcutaneous insulin once they're out of the ICU. Very briefly about subcutaneous insulin. The thing is, intravenous insulin has a very short half-life. So before you stop it or the patient starts eating, you need to give a subcutaneous insulin maybe an hour or 2 before that, in case the patient is not eating. But when you stop it, the blood glucose levels will go high. So classical example is transiting from the ICU to the ward. There would be a lag period of about an hour, 2 hours, maybe longer. In the ICU, the blood glucose levels was 176. When they reach the ward, it is 376. What happened? The nurse switched off the infusion, and because of the short half-life, the sugars escape. Patient is not eating. So in that patient, what should we do? About 3 hours prior to transport from the ICU to the ward, give a long-acting insulin. and very briefly how to calculate the doses of that I'll talk about. The last 4 doses of the infusion, just take them. They'll give you a good idea of the 24-hour requirement of this patient. Comes to 72, don't give the entire 72 units, subtract 20 to 30%. Here comes your skill, your understanding of the patient being insulin sensitive or resistant. Delete 10%, 20%, 30%, mostly we do 20%. Give 50% as basal, and the rest 50 divide it into 3 in the bolus. Here you've got your insulin regimen which needs to be followed in the ward. So I end here. Hyperglycemia management in the hospital, including the critical care setting, has a direct impact on outcomes. In these sick patients in the ICU, it's mandatory, if the blood glucose levels are above 180, to institute glycemic control by virtue of a insulin infusion protocol given intravenously. The ideal protocol is one which is developed by you for your patients in your institution, and the easier form is a intuitive, easy protocol which nurses can drive in the hospital. So I thank all of you for your kind listening.